Hello, a very good evening to all. I am Dr. Dhammadip Dabade. On behalf of Emcure Pharmaceuticals Limited, I welcome you all on the occasion of Empower Talk. Empower Talk is the scientific initiative by Emcure wherein we learn and understand various aspects in diabetes management. Today, we are going to explore, learn, and understand about such topic, the role of pioglitazone based combination therapy in diabetes management in current era. And for that, we have an expert with us. We have expert speaker, Professor Dr. Vijay Panikar sir, and it's my privilege and honor to welcome and introduce about sir. Sir is honorary consultant at Department of Endocrinology, Diabetes and Metabolism at Lilavati Hospital, Mumbai. Sir been ex-professor of medicine at KJ Somaya Medical College, Mumbai. Been ex-vice president of Research Society for Study of Diabetes in India. Past chairman, Research Society for Study of Diabetes in India, Maharashtra chapter. Past president, College of Physicians and Surgeons of Bombay. Organizing chairman, RSSDI National Conference in Mumbai, November 23. Sir has various publications in his credit. More than 20 research publications in various journals, written chapters in textbooks and medicine updates. Pioneering work on triple drug therapy and low dose pioglitazone 7.5 mg in clinical practice. Co-authored RSSDI recommendations for diabetes management, authored RSSDI guidelines for in-hospital management of diabetes 2016 and developed an APP for the same. Thank you, sir, for joining with us. Flow for this meeting will be after a talk by Professor Dr. Vijay Panikar, sir, we will be having interactive question and answer session. And I request all the audience who are with us to be interactive, ask whatever the questions you are having pertaining to this topic. And we will be concluding with the vote of thanks. With that note, I would like to stop here and hand it over to Professor Dr. Vijay Panikar, sir, for his talk. Over to you, Panikar, sir. Thank you.
Thank you, Dr. Dabade, for a kind introduction. Let me share my slides. Okay, let me share my slides. Can you see my slide? Full screen?
It's not full screen, sir.
That means there is an increase in the subcutaneous fat. But you look at the visceral fat, which was 140, comes down to 105. That is a 25% decrease in visceral fat. This visceral fat is the pathological fat, which is causing all the problems, not the subcutaneous fat. So what pioglitazone does is it repositions, removes the visceral fat and deposits it in the subcutaneous fat, which is beneficial for the patient. So increase in weight is there, but basically with proper diet and exercise, that can be easily taken care of. So it does cause weight gain, but lowers visceral and hepatic fat. Then we come to congestive heart failure. We all are worried about congestive heart failure, and what the current guideline says that if the ejection fraction is less than 45, avoid using a pioglitazone. But how did this story about heart failure come? This is from the proactive study. And in proactive study, what was the proactive study? It was a study wherein they used pioglitazone in patients who already had a myocardial infarction. And what did they show? That the recurrent fatal and non-fatal MI is reduced by 28%, acute coronary syndrome reduced by 37%, and the secondary stroke reduced by 47%. Now, this reduction in stroke by 47% was a really outstanding thing which was seen with pioglitazone. And that is how, based on these findings, that subsequently an IRIS study was done, about which I will talk later. But here they found that the incidence of heart failure increased in those patients who were given pioglitazone. It was, I mean, in the pioglitazone, it was about 11, and in the non-pioglitazone, it was 9, 8 or 9. So there was an increased incidence, but the beauty of it is there was no increased death. Even in those patients who had a heart failure, those who were on pioglitazone, they survived more than those who had heart failure without pioglitazone. So this I've already spoken. Then we come to the bone fracture. This is a big hype thing that, oh, it causes bone fracture. But this pioglitazone has been associated with reduction in bone formation markers as well as reduction in bone mineral density. But this is basically seen in postmenopausal women. And in men, there is no increase in the amount of fractures. So if you have a postmenopausal woman nearing 60, it is better to avoid a pioglitazone. But there again, in circumstances where I feel that this patient needs a sensitizer, then what we do is we get a BMD done, bone mineral density. If the bone mineral density is good, then very safely we can use the pioglitazone. But if they are down, then we don't use the pioglitazone. We could consider other sensitizers, like maybe even a saroglitazone or even a hydroxychloroquine, which works good as a sensitizer. Then we come to bladder cancer. This was the most hyped, talked about side effect for which pioglitazone was almost hanged. And in 2013, the government of India banned pioglitazone. And probably I was one of the persons who called a press conference in Mumbai, and along with Dr. Rajiv Kovil and the late Siddharth Shah. And then the whole thing went viral. And in a month and a half, the ban on pioglitazone was withdrawn, thankfully. So that was as far as bladder cancer is concerned. But if you see, all these studies have shown that bladder cancer is not a major risk factor with pioglitazone. And this is a beautiful comment by Robert Ryder and Ralph DiFranco, which says that pioglitazone is inexpensive, very effective at reducing HbA1c, no evidence of bladder cancer risk, and plenty of evidence of cardiovascular benefit. So in this heading of this comment, it sums up all the plus points of pioglitazone. So type 2 diabetes, what is the present day scenario? See, this is a simple chart or a diagram which shows that if this is a lifespan of a normal Indian, it is about, if you see, a 30-year-old Indian is expected to live up to 75 years. But if you have a 30-year-old diabetic, he stands to lose 14.5 years of his life. That is tremendous loss of life. So when we are treating type 2 diabetes, this is what we have to look at. We should not be just sugar controllers. We should look at the thing that my patient should not lose that 14.5 years of his life. And in fact, he should live much longer, much healthier, and better. That should be our motto. And what do patients of type 2 diabetes really die of? 80% of them will die of a macrovascular disease. That's a coronary artery disease or stroke. And a huge number of them will die of renal failure. Look at this. This is the UKPDS study, which showed the benefit of good glycemic control. And they said that everybody should have an HbA1c below 7. And all the national guidelines followed suit immediately. Oh, that yes, HbA1c 7 is the target. Look at this. This is the ADA ESD guideline for 2006. It says lifestyle intervention and metformin. And then look at this. It says if HbA1c is more than 7, you treat. Yes. If it is less than 7, you don't treat. So this was an era where it was just being glucose centric, that based on only look at HbA1c. Then people thought that, oh my God, if HbA1c 7 gives you these benefits, maybe we could get down the HbA1c to 6.5 and we will get much more benefits. So there were some studies, major studies for intensive glucose control in the real world population. And these were the three major studies that came in, the Accord, Advance, and VADT. And what did they really find? Nothing. They only found that intensive glucose control, other than nephropathy, there was no advantage. The Accord was stopped in between because of increased mortality, weight gain, and hypoglycemia. So what is the basic take from here? See, basic you have to understand is that glycemia is the driving force for microvascular complications like retinopathy, nephropathy, and neuropathy. The macrovascular complications are not really driven by glycemia. Look at this study. This is a ticking clock hypothesis. This is a nurses' health study. I will not go into the details of this study, but the net result of this study is that the elevated cardiovascular disease risk begins at least 15 years before the diagnosis of diabetes. So what are we talking about HbA1c? He is already developing all the risk factors for going in for cardiovascular problems. So if you see Indians, they become diabetic at least 10 years before the Caucasians or the whites. They develop coronary artery disease much earlier than the whites. And they have very bad coronary arteries. This is because this has been happening much before the onset of diabetes. So our outlook has to change. That it is not just glycemic control, it is a multifactorial control. And in fact, in 1990, the Steno-2 study came, which looked at all the factors, glycemia, good blood pressure control with ACE inhibitors or ARB, statins for lipids, and they showed that you can have 50% decrease in mortality. So what is the big message from all this? The big message is that good glycemic control does not prevent heart attack. And you can die of a heart attack with an HbA1c of 6.5, telling us that heart attack is a multifactorial thing and not really related to only glycemic control. So the optimal treatment should be a good glycemic control and treatment of the dysmetabolic syndrome. When you say good glycemic control, that is going to address your microvascular complications. Get this very clear. But for macrovascular complications, what you need to address is the dysmetabolic syndrome, which is part and parcel of type 2 diabetes. That is insulin resistance, obesity, hyperinsulinemia, hypertension, dyslipidemia, premature atherosclerosis, and a procoagulant state. So this is what you need to address. So pioglitazone has a decent HbA1c lowering potential, which is similar to metformin, GLP-1, DPP-4, and SGLT2. All of them, on an average, will reduce the HbA1c by 0.8 to 1, depending on what the initial HbA1c is. And if you look at this, what are all these medications which are available are for control of glycemia. and they all will work. But the question is, what do you select and why do you select? What leads to the progression of type 2 diabetes is the apoptosis of the beta cell. As the beta cells will die, your diabetes will keep on progressing. This is the very old slide from Wikipedia, which says that at the time of diagnosis, more than 50% of the beta cells are gone. And over a 6-year period, there is a steady decline in the beta cell mass. And this decline in beta cell mass, that means less insulin, that means sugars are high, number of medication will go on increasing. This is what leads to the progression of type 2 diabetes. So if we can somehow preserve that beta cell, we could delay or even stop the progression of type 2 diabetes. These are studies using sulfonylureas, where you see initially, in fact, 12 studies. Initially, there is a good decline in HbA1c in the first 1 year. But then gradually the HbA1c begins to rise. What is this telling us? That the beta cells are dying. That there's a progression of the disease in spite of the fact that we have treated and controlled the sugars very well in the first year and a half. But look at this. These are about 8 studies which use glitazones, pioglitazone and rosiglitazone mainly. You see the good reduction in HbA1c, but that reduction is maintained for a period of 5 years and plus. And in fact, I have got so many patients who are well controlled with this combination for a very, very long time, much more than 5 years. So this tells us that this has the potential of preserving beta cells. And what really leads to the apoptosis of the beta cells? Hyperglycemia, glucotoxicity, insulin resistance, but mainly the lipotoxicity. So if you look at the beta cell function improvement with a PPAR gamma agonist, in yellow what you see is it causes mobilization of the toxic lipid metabolites out of the beta cell. That means it reduces lipotoxicity and thereby helps to preserve the beta cell or delay its apoptosis. So when you come to insulin resistance, so basically for preserving beta cell, you only have one molecule today, and that is pioglitazone, which will give you a long, durable, sustained control of your sugars. Insulin resistance. Almost 83% of type 2 diabetes are insulin resistant. And this is a slide which tells you the basic impact or the consequence of having insulin resistance. Look at the picture of this man with a pot belly. This is very typical Indian phenotype. If you see a European obese person or an American obese, he's fat all over. But you see an Indian who is fat, he is there with his paunch right out. And this is the typical Indian phenotype, which signifies severe insulin resistance. And if you see this last panel, clinical consequences of insulin resistance, it can cause diabetes, hypertension, ASCVD, heart failure, sleep apnea, PVD, stroke, PCOS, and NAFLD. So when you treat insulin resistance, you are treating all these conditions simultaneously. So is there evidence that treating insulin resistance can help? Yes. You have treatment options, non-pharmacological and pharmacological, diet, exercise, and weight reduction. Any form of exercise and weight reduction is going to reduce insulin resistance. And that is where the role of a GLP-1 agonist comes. And now you have the twin cretins, your Monjaro, that is a GIP and GLP-1 agonist with very significant weight loss. And now you have a third molecule which was just presented at the ADA, retatrutide, which causes good weight reduction, about 20 to 22% weight reduction in about 48 weeks. So that weight reduction can work as a solid stimulus for reducing insulin resistance. Pharmacologically, you have metformin and pioglitazone, but as far as insulin resistance is concerned, it is only pioglitazone. Metformin does not reduce insulin resistance. All it does is reduces hepatic glucose output. The all the studies of diabetes prevention studies looked at diet, exercise, and metformin, and there were a few drugs which use glitazones. Your tripod study, pipod study, dream study, act now study, which showed fantastic results as far as prevention of new onset type 2 diabetes. And the sole reason for that is the treatment of insulin resistance. Now we come to the IRIS study. Like I told you earlier, in the proactive study, there was a 47% reduction in stroke. Based on that, the IRIS study was formulated by a group of neurologists. And what did they look at? They looked at patients who had a recent TIA or an ischemic stroke. And they were non-diabetic, mind you. This is in non-diabetic patients. And they checked for insulin resistance. If the HOMA was more than 3, they labeled them as insulin resistance. And they were treated with pioglitazone 15 to 45 milligrams as with a control of with placebo. And they were looking at non-fatal, fatal MI and stroke. And what did they find at the end of 5 years? Recurrent stroke reduced by 24%, myocardial infarction reduction was 24%, and new onset of diabetes reduced by 52%. So this is for the first time that a therapy directed only at insulin resistance in a non-diabetic population has shown to prevent cardiovascular and cerebrovascular events for these patients. Now, in this subgroup, in this same study, there was a subgroup of patients, about 2,885, who were pre-diabetics. They were not diabetics. They were pre-diabetics. And those with good adherence to pioglitazone, if you look at the figures, they are mind-boggling figures. Stroke and MI jointly reduced 40%, stroke by 33%, acute coronary syndrome reduced by 52%, and new onset of diabetes by 80% over a median follow-up of 4.8 years. So here you have a pre-diabetic who is treated with pioglitazone, and this is the kind of results that you see, which no other molecule today gives. No other cardioprotective molecule, no statin, no GLP-1, no SGLT2 gives this kind of figures. So based on this, the American Heart Association and American Stroke Association have now begun to recommend pioglitazone for prevention of recurrent stroke. Now, NAFLD is on the rise. It's an epidemic. And today, NAFLD is becoming the major cause for liver transplant in the United States. And if you look at the randomized controlled trials reporting improvement in NAFLD features like NASH, NAFLD activity score, steatosis, and so on, everywhere you find, see, the drug which has the best results is pioglitazone, 30, 45 milligrams everywhere. Here you see a liraglutide giving you a benefit here. That is by virtue of his weight loss. Because NAFLD is driven by insulin resistance. So if you treat insulin resistance, and that is the treatment of choice today for NAFLD. If you look at this, this is the ACE guidelines of 2022, which says the treatment of fatty liver or NAFLD is pioglitazone, pioglitazone, pioglitazone all the way. You can, of course, use the GLP-1 also. And one of the studies says GLP-1, pioglitazone, or SGLT2. The ADA guidelines for 2023 for NAFLD says use pioglitazone or a GLP-1 receptor agonist. It should be and or a GLP-1 agonist. So you have across the board. So all the associations now are recommending that you should use a pioglitazone or a GLP-1 to treat NASH. Now look at the effect of pioglitazone on CV risk factors and biomarkers. It significantly increases HDL cholesterol, which is a strong predictor of cardiovascular mortality in patients with type 2 diabetes. And you look at the anti-atherogenic and cardioprotective effects of pioglitazone. 4 randomized controlled trials, very excellent trials. Proactive, Chicago, Periscope, and IRIS. IRIS we just discussed. The proactive also we had discussed, heart failure. When we come to the Chicago trial, it looked at the carotid intima media thickness. It was compared against glimepiride. The red what you see is glimepiride. Over a period of 72 weeks, the carotid intima media thickness on patients on glimepiride increased, whereas patients on pioglitazone decreased. suggesting the anti-atherogenic property of pioglitazone. Then we come to the Periscope trial, where again pioglitazone versus glimepiride, and this was done by Steve Nissen. Steve Nissen, you all know, was the person who showed that rosiglitazone causes an increased incidence of coronary artery disease. And that is how rosiglitazone got banned. That was Steve Nissen. And he did this study on pioglitazone using IVUS, intravascular ultrasound of the coronary arteries, wherein they looked at the atheroma volume and they gave glimepiride to half the patients and pioglitazone to half over an 18-month period. And what did they find? That the atheroma volume increased in patients who are on glimepiride, but significantly reduced in patients who are on pioglitazone. So here again, it shows that it is an anti-atherogenic drug. So Chicago and Periscope study shows that pioglitazone is anti-atherogenic. This IRIS study I have just discussed earlier with you, but this is a very interesting study which was done from a European multi-base cohort study by Helen Strongman, wherein they looked at patients who were exposed to pioglitazone and patients not exposed to pioglitazone. 31,000 patients in both the categories, and they looked at cardiovascular and non-cardiovascular deaths. So look at this. This is the patients who are exposed to pioglitazone. The cardiovascular death was 691, but look at those who are not exposed to pioglitazone. It is 3 times more. Non-cardiovascular death, all-cause mortality, 3 times more in patients who were not given pioglitazone. This is a European database. And if you look at just cardiovascular specific cause, myocardial infarction, stroke, and heart failure, we all say that pioglitazone causes heart failure. But look at the those who did not receive pio, they have 3 times more chances of heart failure, 3 times more chances of stroke, 3 times more chances of myocardial infarction, telling us that pioglitazone use has a lot of cardioprotective benefit. So this trial suggests that pioglitazone should decrease in both cardiovascular and non-cardiovascular mortality. So this is to sum up the benefit of pioglitazone. It reduces stroke, reduces carotid intima media thickness, acute coronary syndrome is reduced. It can reduce stroke. It can also reduce microalbuminuria as shown in the quartet study. But very importantly, it can reduce necrosis, inflammation in NASH, and reduce by 50% the risk of these patients developing a hepatocellular carcinoma. So, though it was almost hanged without a proper trial, there are very favorable things with pio. It reduces insulin resistance, no doubt about it. In fact, Indians are an insulin-resistant population. It preserves the beta cells, no doubt about that. It has a durable glucose-lowering effect, which is seen across the board in all the studies that have been done. It improves the lipids, increases HDL, very nicely done. It has anti-inflammatory effects and may reduce cardiovascular events, as seen from Helen Strongman study, as seen by the your proactive study, as seen by the IRIS study, and improvement in NAFLD. All the gastroenterology associations are also recommending pioglitazone as a primary agent for treatment of NAFLD. So what would be the ideal algorithm to treat? So when you talk of ideal algorithm, what are you really looking at? You want to first reduce peripheral insulin resistance. And that is done by glitazone and metformin. You want to preserve the beta cell so that the progression of the disease is halted. You have the glitazones and metformin. And you want no hypoglycemia. Now, when you say no hypoglycemia, there are only 2 molecules in diabetic therapy which will cause hypoglycemia, a sulfonylurea and an insulin. So that would be relegated to the last. You have a DPP-4 inhibitor, you have a GLP-1, and you have a SGLT2. So you can use any of these molecules in combination with a glitazone and metformin and get the desired results without fear of hypoglycemia. You can sleep comfortably once you prescribe only these molecules to your patient. But if you can't control with this, then you need to add a sulfonylurea. And of the sulfonylurea, what I most prefer is a glycoside modified release, which has been shown in the advanced study to cause minimum hypoglycemia and shown some renal benefits also. If you have only a postprandial hyperglycemia, you could add alpha glucosidase inhibitor. And if after all this, still your sugars are not controlled, that is when you can think of adding insulin. Among all these molecules, sulfonylureas and insulin have no pleiotropic effects as far as cardioprotection or nephroprotection or liver or brain. The only molecules which have that is a glitazones and a SGLT2. So what should be the strategy? Macrovascular damage starts many years before the onset of diabetes. Insulin resistance and its complications and beta cell preservation have to be adequately addressed for positive long-term outcomes. If insulin resistance is treated right from day one, we will see lesser macrovascular complications, obviously so, which has been seen in even IRIS study. Pioglitazone metformin is most durable combination, less weight gain. But if you add an SGLT2, that's an unbeatable combination. Metformin pio gives the best results when endogenous insulin is present, and the best combination would be metformin pio and SGLT2. Now the question here is, we don't have any combination which has metformin pio and SGLT2. And even if we do have, the problem here would be about 10% of the patients, we will have to remove SGLT2 molecule because of balanitis, vulvovaginitis, urinary infection, polyuria, and so on and so forth. So here, what we today have in the combination is the combination of sitagliptin, metformin, and pioglitazone. This could be a stable baseline bulwark for you. And you can add an SGLT2 separately to this. Absolutely no problem in having 4 drugs. We have published data on that. And it can be a wonderful combination for long term without the fear of vulvovaginitis or balanitis. And it has shown good benefit there. So basically, to conclude, pioglitazone is a very valuable treatment option in Indian type 2 diabetes because Indians are insulin resistant. Benefits far outweigh the risk in those patients responding well to pioglitazone. Careful selection of patient and monitoring the response will help in optimizing treatment with patients. See, basically, when you're using a pioglitazone, you should know where not to use it. In any patient, female above 60, do not use it. In a patient who has a cardiac problem with a low ejection fraction or a history of myocardial infarction or a bypass surgery or a stenting, preferably avoid using pio. If somebody has persistent edema feet and in spite of lowering the dose of pioglitazone, still they have edema feet, discontinue. Because those patients who have edema feet on pioglitazone are the ones likely to be candidates for heart failure and even macular edema. So if you look at these problems, rest of the thing, you can very safely use pioglitazone in all your newly diagnosed type 2 diabetes in combination with any of the drugs, hopefully other than sulfonylurea and insulin. Thank you very much, ladies and gentlemen, for a patient hearing. And I would be only too happy to take questions from you.
Yes, sir. Very insightful session, sir. We had the way you just elaborated on this pioglitazone based combination therapy, specifically when it comes to it with metformin and sitagliptin, rather than the dapagliflozin, which you very well given the rationale behind that. So I request the audience and also to coordinate Ankit to just put the question me if any there so that we could take the questions. Meanwhile, Ankit share with us the question. Sir, I would like to ask one question pertaining to this combination, pioglitazone, metformin, and sitagliptin. So, which patient profile can be the best suitable profiles when it comes to this particular triple combination therapy, as
See,
per your viewpoint?
basically all newly diagnosed type 2 diabetes, this combination would work. Any of the patients, even long term, who are on these three drugs, you could use a single drug. So the scope is wide. In fact, what we do in our clinic is every patient should get a metformin, pio, and SGLT2 unless there is a contraindication. And then we add on a DPP4. If that doesn't help, we add a sulfonylurea. And that doesn't work, we add a. I mean, like I discussed, that's exactly what we have an algorithm and it's on my program. It generates an automatic prescription based on that.
Well noted, sir. So parallelly also, there is one question. Acha, I could see one question in the chat box. Sir, what is the methodology to identify the insulin resistance? As you mentioned about the insulin resistance as one of the
See,
pathophysiology, but how to identify?
let's get one thing very clear. We Indians are a ethnic race who are insulin resistant because we were a country who was poor, who did not have food. So once you have that starvation, famine, I mean, I remember when I was a student and even in college, we had only ration shops. Probably you have never seen a ration shop. We have to go every month and collect the ration, which would be just sufficient for the family for the whole month. There was no department store where you could go and buy rice and wheat and no, nothing of the sort. It was only at the ration shop, fair price shop. Today, it is plenty. You have KFCs, McDonald's, Vada Pavs, Pani Puris, and you name the thing. And you go to any mall, you can pick up whatever you want, right from snacks to biscuits to rice to oil, everything. Previously, nothing was there. So we were a poor nation with no food. And that sets in insulin resistant in our population. So what is the methodology? Forget the HOMA and everything. If anybody has a central obesity, he is insulin resistant. Full stop. That is one. Second is you look at the lipid profile. If the lipid profile shows that the triglycerides are high and the HDL is low, that is a typical dyslipidemia of insulin resistance. These two factors will be there in practically every type 2 diabetes. So they are insulin resistant. So there is no need to go into fancy HOMA and all the insulin levels and nothing is required. Just clinically you can see somebody who has acanthosis nigricans, somebody who has skin tags, somebody who is obese with a central obesity is insulin resistant. Full stop. Very clinical and practical.
Okay. So that's very again insightful, sir, when it comes to insulin resistance and the way you just given the insights about. Then, sir, another question comes about whether there is something around the BMI when it comes to the usage of pioglitazone. So, is there something like maybe obesity or the BMI range which makes the usage of pioglitazone in particular patient? Do you
Now,
do?
see, basically,
Okay.
Indians, I mean, there is a very nice picture of Professor Yudzgik and Professor Yagnik, where they both have the same BMI, which is 22.3. But if you look at their body fat content, Yudzik has 9%, whereas Professor Yagnik, Indian, has 22% body fat. And that is how the paradox came that Indians are thin, fat Indians. They are thin with a low BMI, but they have more fat. And that is where the insulin resistance comes from. So, and another thing is, in fact, recently I was speaking to Dr. Ralph DiFranzo, who is the person who showed the ominous octet. And I had him for our conference RSSDI 2023, which we had in Mumbai as a guest speaker. And he said that those patients on pioglitazone who tend to gain weight are the ones who are most benefited by pioglitazone, and they will live 5 to 10 years longer. And he went on to say that it is very simple. If I have to think that this patient of mine is going to put on 5 kilos weight and he is going to live 10 years longer, I would prefer that he has 5 kilos weight rather than not giving him the drug and making him lose 5 kilos weight and killing him 10 years earlier. This is his exact statement.
Well noted, sir. Thank you for again the yet another insight. There is one question, sir. There are so many doctors who are still hesitant to use pioglitazone. What's your message to them? So probably this
I
question is
think
around the yes, sir.
see, this has been a very unfortunate thing that people are scared to use, are uncertain how to use, probably they don't have the experience how to use, or they don't know where not to use. But it has been built into them over a period of time. In fact, I have seen that many a times some of the teaching sessions which they have case representation, they don't discuss the role of pioglitazone at all. They will keep it aside and talk of everything else, which is a very unfortunate situation. And I feel sorry for them. I think they should all be using pioglitazone unless there is a contraindication. And if they don't use pioglitazone, I think they are doing disservice to their patient.
Well noted, sir. So message is very clear when it comes to the pioglitazone usage. Unless and until it's contraindicated, it has to be used. That's the message clear. Yet another question. So in the chat box, in which patients will the CETA plus DAPA plus MET combination may be useful?
See,
CETA, DAPA, MET. Yeah.
See, all these individual molecules, whether it is metformin, SITA, or DAPA, have their own benefits. DAPA has its benefits as far as reducing cardiac failure and even having benefits in renal function. It can reverse a lot of albuminuria and prevent even new onset of uh, albuminuria in patients with diabetes. So these are molecules which are available, and there is no fear of hypoglycemia. That is the most important. That's a rate limiting factor in treatment of diabetes. If there was no hypoglycemia, you would not need a diabetologist or an endocrinologist to treat these patients. Anybody could treat. Bindas dev dawa and nothing to worry. Dekha jayega. So this, if you remove sulfonylurea and insulin, that is exactly what will happen. Very comfortably, without fear of hypoglycemia, you can treat them with these molecules. And all these molecules generally would give you a 0.8% reduction in HbA1c.
Yes, sir. That's noted. Yeah. So now coming to again this combination CETA-MET PIO. Uh, what if we will replace this CETA with GLIME and the combination will be like I will go with the GLIME MET and probably CETA. So another combination which having glimepiride along with sitagliptin.
See,
So
basically,
how? Yeah.
when you're looking at a newly diagnosed type 2 diabetic, you need sometimes, if the HbA1c is more than 11, you need to give a sulfonylurea along with metformin, pio, and a DPP4 and an SGLT2. Sulfonylurea is the fifth drug. And by and large, within a month, this sulfonylurea will come off. So rather than putting the sulfonylurea into a combination and disturbing the entire milieu, use sulfonylurea separately. Your metformin, SITA, pio would be a good combination to use with an add-on SGLT2 separately. So keep this as your base, add a SGLT2, add a sulfonylurea, and as the things regress, then you may want to knock off the sulfonylurea. But I would not be very happy putting a sulfonylurea into a combination with this.
And if we really want to have a kind of maybe comparison, or let me put as a head-to-head comparison when it comes to the triple combination with this Sitamet Pio versus Sitamet Glimepiride. So which triple combination may be
No,
comparatively
see,
better?
whenever there is a
There is a
sulfonylurea on board, it is more powerful hypoglycemic agent. So if you have a Sita, Met and Pio, or a Glimepiride, Met and Pio, that Glimepiride is much more potent hypoglycemic effect. And there is a chance of your patient going into hypoglycemia very rapidly. So it is not a head-to-head comparison. Sulfonylurea and insulin are very potent hypoglycemic agents. It can bring down the HbA1c up to 2. Insulin can bring down up to any level. So that is a different ball game altogether. If you ask me head-to-head comparison of metformin, Sita and Pio, or metformin, Pio and SGLT, they are comparable. But SGLT will have different benefits, very much superior to this combination. But unfortunately, there is no combination with metformin, Pio, and SGLT2 as of today. The DGCA has not yet approved any combination for that, though people are trying desperately for it.
well, there is another question about just sitagliptin. It is said that sitagliptin empowers patients for 24-hour glycemic control. So, is it? I mean, what's your opinion on that? Sitagliptin can go with the 24-hour control.
See,
Is
whether
it
it
really
is
that so?
with any of the DPP4, most of them act for 24 hours except a vildagliptin, which needs to be given twice a day. Even that, an OD preparation has come, which claims to work 24 hours. And the HbA1c lowering capacity is about 0.8% for all the DPP forms, whether it is Sita, Vilda, Tenali, or any. 0.8% HbA1c reduction. But if the HbA1c is very high, it might go even up to 1.5%. But on an average, if your HbA1c is around 9, you can expect a 0.8% reduction by use of any of the DPP4 inhibitors.
So now there is one question about the initiation of triple combination therapy. So what should be the point where somebody can think about the starting with triple combination? So what's your
See,
message about?
any newly diagnosed type 2 diabetic, in fact, we have got a very simple algorithmic formula for treating. And we only look at the fasting and the postprandial sugar. First, newly diagnosed diabetic coming to me first time, and he doesn't have an HbA1c, but there is a formula to calculate HbA1c, which is available as an app on Play Store also. That is incorporated into my EMR database. So the moment I put a fasting and post lunch, it gives me an estimated A1C. And what our formula says is, if the HbA1c is between 7 and 9 of this newly diagnosed, we give a triple drug combination of a metformin, pioglitazone, and a SGLT2. If it is between 9 and 11, we add an DPP4 inhibitor. And if it is above 11, we will add a sulfonylurea. But if the patient is toxic and things like that, or he has ketones, then we would go for insulin, obviously. So you have to start a triple drug right from day one. And every triple drug should contain a pioglitazone, as I have shown in my talk, that the benefits of pioglitazone are, I mean, no other molecule can come close to it.
Yes, sir. So there is one question about the usage of conventional versus modern triple combination. I'm not sure what he is asking about.
No,
So,
I know what he's
what's
asking.
your take?
See,
Mhm.
conventional means always there was a, you had a triple drug combination of a metformin, pioglitazone, and a sulfonylurea, which was what was standard because no, there were no other molecules then. That is ancient history. But today we have different molecules. So that conventional, so-called conventional is outdated. We don't need that. We have better molecules. You have an SGLT2, you have a DPP4, you have a pioglitazone, which was not there earlier. And in fact, the first triple drug combination paper in the world was mine, which was a glibenclamide, metformin, and pioglitazone. And it was based on that paper that all our companies came out with triple drug combination of a sulfonylurea, metformin, and pio. And they did extremely well because that time we did not have any other molecule. The DPP4 came in 2005 or 6. SGLT2 came in 2012. So when you have those molecules today, and of course, when they came also, their price was prohibitive. We could not use it freely in our patients. So the question of getting them in combination did not arise. It is now that they have gone off patent that every company is coming out with a triple drug combination with these drugs. So it is change in scenario. That is outdated. This is the current.
Noted, sir. Sir, there is another question about the sitagliptin. What is one thing that differentiates sitagliptin versus all of DPP4 inhibitors? So, which one thing which differentiates? So, question is about sitagliptin.
See, basically, I think all DPP4s have the same level of HbA1c reduction. All right. Now, when you talk of DPP4 inhibitors, the US FDA has got a black box warning that it can cause heart failure because all the DPP4s have shown an increased incidence of hospitalization for heart failure. The only DPP4 which has not shown that is a sitagliptin. The TICOS study showed that there was no increased incidence of heart failure with the sitagliptin, with yes. But US FDA has overlooked that and still put sitagliptin also in that bracket. But last, what I know is they were reconsidering removing sitagliptin from that. So where I have a cardiac patient with who has had a myocardial infarction and other things, there I would prefer a DPP4 inhibitor, which I feel is relatively safe with no evidence. Though it is labeled with that it can cause heart failure, but the studies have not shown any increased incidence, and that is sitagliptin.
Yes, sir. So that's really insightful and interesting to learn and understand from you all about this triple combination and specifically the pioglitazone, the way you just given us the insight. And we are almost at the finish line, and I'm happy to share with you we have almost 390 audience live with us, and almost 1600 plus were enrolled for this program. And with that note, I would like to hand it over to Mr. Ajay Ghodke for the vote of thanks for this particular program. Over to
Yeah.
Mr. Ajay.
Thank you.
Thank
Thank
you,
you.
Dabade.
Thank you,
Yes.
Dr. Damadip Davade. And thanks a lot, Dr. Panikar, sir. It was an excellent talk. And I would like to thank all the delegates who's attending this session. As you rightly said, sir, insulin resistance is much serious problem in India, and pioglitazone has a pivotal role and can be used as a major treatment strategy. And in current scenario, the ideal combination with the pioglitazone with sita and metformin, I think it has really shown us a path. So your expert insight will always be useful, sir, to treat diabetes patient effectively. And Emcure being a research-driven pharma company, we will always keep doing such academic programs. We are really enlightened today, sir. We are very fortunate to have you. So thanks a lot again. Thanks, audience. Thank you, Dr. Dhammadeep. Thanks for the excellent talk.
Thank you, the entire team of Emcure, and thank the audience for patiently listening to me.
Yes, sir.
Thank you.
Thank you.
Yeah. Thank you, sir. Thank you very much
Thank
once
you.
again.
Thank you.
Thank you,
Thank
sir.
you.
See you. Very good night and good time ahead.
Yeah, good night.
Thanks a lot, sir. Thank you.
Thank you, Buddha.
Thank you, sir.